Strokes, also called a CVA, is what happens when the brain lacks oxygen, typically due to a clot in a blood vessel, which cuts off oxygen supply to the brain. So, just like any organ without oxygen, the brain begins to die. But strokes can also be caused by narrowed blood vessel, which decreases oxygen delivery to the brain, like in atherosclerosis, or even sudden rupture of a vessel in the brain, known as an aneurysm. Either way, the brain lacks oxygen and tissues die. Now for the type of strokes, we have TIA, known as a transient ischemic attack, which I remember TIA as a tiny stroke, since we have a tiny lack of oxygen. Now, breaking down the medical terminology, transient means lasting only a short time, ischemic means a lack of oxygen, and attack means it happens suddenly. But TIAs come and go and often resolve by themselves. Now, the other types of strokes are more permanent. So a CVA, a cerebrovascular accident, just think CVAs are more serious. We have no oxygen, which means long-term permanent damage. Now, there are two types of CVAs. Ischemic, meaning that low oxygen, typically from a blood clot that cuts off oxygen supply, also called embolic or thrombotic stroke, and a hemorrhagic stroke, like an aneurysm, so bleeding from a ruptured blood vessel, resulting in high risk for increased ICP. Now, the number one risk factor and cause to know for the NCLEX and nursing exams, write this down, is hypertension, over 140 systolic. This one was stressed as the single most important risk factor to prevent a stroke.
Click here to check out our brand new app-based NCLEX product, loaded with the highest quality NCLEX style practice questions, and complete with detailed video rationales that break down the question for you. So finally master all those darn select all that apply questions. Plus, all our NCLEX memberships come included with our entire library of over 1,000 videos and study guides and cheat sheets. Come see why over 100,000 students have trusted their future to simplenursing.com. Click here to get started for free.
So the key term for prevention was to instruct the patient to take their antihypertensive medications regularly, since the stroke risk can be decreased by up to 50% when hypertension is controlled. So Hesse mentions the highest risk for a stroke was that hypertension, over 140 systolic. And Kaplan says that hypertension was the highest risk factor for a CVA. Well, why though? Well, think of the patho here. Uncontrolled hypertension pounds those little blood vessels inside the brain, stretching them out and making them very fragile. Now, a tricky NCLEX question for a client recovering from a stroke with hypertension over 200 systolic, the intervention was to keep the systolic blood pressure over 170 for the first 24 to 48 hours. This makes sure we lower the pressure slowly, sort of like landing a plane. We land it slow and smooth, no big drops. This prevents us from crashing into hypotension. So remember, we need to land that plane slow and steady. Now for the other causes that weren't really tested, smoking scars the blood vessels, making them weak. Hyperlipidemia, that high cholesterol, adds fatty buildup underneath those scarred vessels to form plaque. And uncontrolled diabetes, we get very thick, syrupy blood, which puts loads of pressure on the blood vessels and over time destroys the whole body. And even increased risk for clots, like in clients with atrial fibrillation and even heart valve malfunctions, where blood can sort of swirl around the heart, resulting in clots that can eventually travel to the brain. Now for the key signs and symptoms, the most tested key term on 5 different question banks was, write this down, hemiparesis, or unilateral weakness. That one-sided weakness that was new or sudden, with key term arm drift. Guys, write that down. These key terms came up 90% of the time. So if you see these terms, new or sudden, or even one-sided weakness, or even arm drift, you have to assume that it's a stroke, and we have to notify the provider immediately. So for quick assessment, we use the popular acronym FAST, since acting fast saves lives. So F for facial and smile drooping, A for arm drift, that one-sided weakness, S for speech impairment from the mouth and tongue, And then T for time, we have to call 911 and get a CT scan immediately for any of these signs and symptoms. Since this is known as the golden hour, we only have 1 hour to seek medical attention due to the lack of oxygen supply to the brain. Remember, time is brain. Now for hemorrhagic strokes, that ruptured cerebral aneurysm, we get a key sign for severe headache. Now this is very different than any other type of headache. It's way worse than migraines. Some clients even say that it's the worst headache of their life, often called the silent killers, because a small bleed can go undetected for years before a major rupture without warning. So a common NCLEX question is, the most concerning patient statement with diplopia and new weakness and onset of vomiting without nausea. I have the worst headache of my life. The key term there is worst headache, since blood is filling up that brain, causing massive increased ICP. Now, since strokes affect one side of the body, a left brain stroke will affect the right side of the body, and vice versa. A right-sided stroke will affect the left side of the body. So to help you remember this, just think of an X coming out of the brain and pointing down to the opposite sides of the body. So write this down. Left brain controls the L's, language and logic. So we see dysphagia, difficulty speaking. So just think the S in dysphagia, S for speech. And we get reading and writing problems. And we get right-sided hemiparesis, that one-sided weakness, resulting in right-sided neglect, basically ignoring that side of the body due to the half vision from visual deficits. And on the other side, the right brain, think of the R's, reckless and really creative. So we get lack of impulse control and behavioral changes, as well as left hemiparesis, that one-sided weakness on the left side, leading to left-sided neglect from ignoring that body due to the half vision. Now, a common NCLEX question is teaching for families of patients with right-sided brain injury. So remember, R for right side, R for reckless. So the correct answer is always lack of impulse control and behavioral changes. Now, the ATI mentions manifestations of right-sided hemispheric stroke. So expected findings is visual and spatial deficits, left homonymous hemianopsia, basically that one-sided vision, as well as one-sided neglect. These are typical for almost every stroke patient. Now for diagnostics, the number one goal here, as mentioned before, is a CT scan immediately. We need to take a picture of the brain and pinpoint the exact cause. We need to know this first before we start treatment, since treatment will be very different depending on the type of strokes. So in terms of treatment for pharmacology, strokes with clots, we give a clot buster. So write this down. Thrombolytics are given within 4.5 hours of the onset of the symptoms. So TPA and those ending in ACE, like alteplase and streptokinase. Common exam questions, especially select all that apply, come from this section. So the key terms are give thrombolytics in 4.5 hours of the onset of the symptoms. So if a stroke happens 2 hours prior to the hospital, you know you have about 2.5 hours to give the clot buster. Now on the other side, if stroke is hemorrhagic, we can't give a clot buster since there's no clot. So number one thing we do is we implement seizure precautions and strict bed rest, since increased ICP is a big risk here from that brain filling up with blood. Now the next thing is no blood thinners, since it will make the bleeding worse. So no aspirin and no clopidogrel, or antiplatelets, and no heparin or enoxaparin, no warfarin, and definitely no thrombolytics. And then very lastly, limit any activity that may increase ICP. A big one on most question banks was key term, administer PRN stool softeners daily to prevent straining and bearing down during those bowel movements. Now, 2 tricky NCLEX questions. So the first one was interventions for the initial plan of care for a patient with suspected embolic stroke. Select all that apply. So the key term here is embolic, or basically that emboli, meaning a blood clot. So number 1, we obtain a stat CT of the head to determine the type of stroke. Number 2, perform neuroassessment. And then number 3, prepare to initiate alteplase within 4.5 hours of the onset of the symptoms. Now, the second common question was a priority nursing action for a patient with left-sided weakness, the lack of verbal response, and a drooping face. The priority here was to maintain a patent airway. So, when given the option, always maintain the airway first. Yes, these are symptoms of a stroke, and yes, it's important to fully assess as well as get to a CT scan, but priority here is always to remain and maintain the ABCs. Remember, airway is always first. Now, as far as patient education, the number one thing to focus on was hemianopsia, that half vision. So hemi for half, and opia means eyes. So just think half of the eyesight. The big key term here was risk for self-neglect, since clients are unable to see that other side of the body. So we teach these key points. Write these down. Dress the weaker side first and apply clothes on the unaffected side first. Now, don't let the NCLEX trick you here. Always dress and care for the weaker side first, not the stronger side, since this will prevent that neglect to that weaker side. The next thing was safety. So number one, we have to scan the surroundings. Number two, turn the head to the affected side. This was mentioned twice by ATI. And for the family, always approach the patient on the unaffected side. And then lastly, again, we're educating the family on the behavioral changes for right-sided brain injury. So remember, right-sided, think reckless. We have a lack of impulse control as well as behavioral changes. Typically, patients are unaware of how their actions can impact their safety, so teaching the family to expect these behavioral changes will decrease confusion and anxiety. Now, as far as nursing interventions, don't try to memorize lists and lists here. Just simply think of the patho. The patient has one-sided weakness, right? So we end up with a weak face and weak swallowing called dysphagia. Huge risk for airway obstruction from that choking. So the key point here is with feeding. NPO until a swallow screen or swallow eval is preformed. And then eating, we have to protect the airway. So number one, we have to flex the neck when swallowing. The key term there, in other words, put your chin to the chest to flex the neck. This facilitates easier swallowing. Now, number two, you avoid sedating medications before the meals. Number three, head of the bed is up in high Fowler's or upright. And then dysphagia, that difficulty swallowing. So a puree diet, not a regular diet. And then we always add thickening agents to fluids. So write that down. That was mentioned a few times. So the ATI says, priority finding in a patient recovering from a stroke. The correct answer was dysphagia with a regular diet ordered. So no, we need a puree diet. That's a priority finding there, since the patient can choke. Huge airway risk. Now, Kaplan mentions a priority intervention for a patient with right-sided hemiplegia, that one-sided paralysis, and the inability to eat without assistance. The answer for this was a puree diet for a client with dysphagia. So remember, airway and feeding is always a priority here. Now, next, we typically implement seizure precautions, we do frequent neuroassessments, and we do cluster care, bundling all your actions into one visit to prevent that sensory overload. So Kaplan says, prevention of sensory overload in a client with a stroke, we obtain vitals and assist with morning care in one visit. Key term there was one visit. Now, in terms of transferring, think weakness. We always use a transfer belt to safely transfer from a bed to a chair. Exam questions love to ask about this, using the key terms of how to use the transfer belt. So always pivot on the distal foot, that foot farthest away from the chair, and always transfer the client toward the stronger side first, not the weaker side. Next, we avoid completing tasks for the client. The goal here is to promote independence to help the client regain function. Now, this is typical for all long-term neuro problems. So common NCLEX questions ask the nurse to provide instructions to help the client perform those ADLs. So write these down. Number one, we patiently allow time for the patient to understand each instruction. Number two, we use simple gestures like pointing and even showing pictures. So for example, we'll show a picture of a shower, a toilet, or even a toothbrush. And then number three, we ask yes or no questions in a normal voice, not a loud voice. So common wrong answers on many NCLEX question banks was speaking in a louder voice to a patient recovering from a stroke. Guys, that's not the problem here. Understanding is the problem, not hearing. So you don't need to speak in a louder voice. So very tricky NCLEX questions and exam questions include the big no-nos. So do not complete tasks for the client. Allow them to learn. Don't speak in a loud voice. Just speak normally. And always allow time for the patient to understand and respond. And then do not give complex instructions or even questions. Simple yes or no questions will do. And then lastly, a little side note for terminology in terms of communication. Dysphagia, think of the S in phasia, S for speech, that difficulty speaking. And then aphasia, or aphasia, think of the A for without speech. Very common after damage to the brain, like in a stroke. Now, don't get tricked with sound-alike words. Dysphagia is not dysphagia, that difficulty swallowing. So just think of the G in dysphagia as G for GI. And then lastly, ataxia is that inability to walk. So A for without, and taxi, think of a taxi cab. You can't get around. So you have inability to walk, and you can't really get around. Now, very lastly, to wrap this up, bronchoaphasia is expressive, the inability to express. So just think B for broncha, think B for big mouth. The client is unable to speak, but they do understand. So the key term here is easily frustrated when attempting to speak. So speech is limited to short phrases. This came up on 2 different question banks. And then Wernicke aphasia is receptive, the inability to understand or receive, but the patient can still speak words that are typically meaningless. So just think Wernicke, you have a weak understanding or a weak comprehension. So the key terms to know was misunderstanding to verbal cues and being unable to comprehend speech. So again, just think Wernicke, you have weak comprehension.
All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides.
Thanks for watching. For our full video and new quiz bank, click right up here to access your free trial. And please consider subscribing to our YouTube channel. Last but not least, a big thanks to our team of experts helping us make these great videos. All right, guys, see you next time.